In this section, we're going to explore how to conduct developmental assessments with young children in early intervention. By the term developmental assessment, we mean in this section those broad category or umbrella of assessment methods that are used to identify how well a child is progressing in their development and if there are any difficulties, delays, or general learning disabilities. So early intervention services often receive a referral from another agency, a GP, a paediatrician, because there are concerns about a child's development. There's concerns that there might be a general learning disability or there might be autism. This referral can occur at various stages. For some, this will be close to birth, either because there was significant prematurity or a chromosomal disorder has been identified, such as Down syndrome. But it can occur for other children later on, between 12 to 24 months, because the public health nurse, in doing their stages developmental check, knows that the child's not progressing as well as should be expected, and some red flags have been identified. So they might make a referral on. This can include not developing speech or not showing the right levels of responsiveness. For other children, this occurs later on once they're in preschool, and the preschoolers note that the child is not learning or interacting or engaging in quite the way that you would expect from the other children. Most early intervention services have some referral process, whether it be an intake mechanism, whether it be a referral committee, where it's identified whether it is an appropriate referral. And if not, it is either referred back for more information or onto another service or just refused. But for those children whose referrals are accepted, there is usually some process of initial contact, some way of making contact with the parents and finding out some more information about this child. And this is frequently referred to as the initial assessment. Now, different services have very different processes by which they do this. And some are more formalized and established than other services. So, for example, in some services that you might work in, once the referral has been accepted by the early intervention service, a social worker might go out and conduct what's called a home visit to say hello to the parents, explain who the service is, and gather some basic information prior to things happening within a clinic. In other services, they have a more formalized initial contact process, which involves more than one therapist meeting both the child and the parent and conducting some sort of initial assessment to gather enough information to determine how the rest of the assessment will be conducted. The idea of the initial assessment is to gather enough information to work out in what way the services should be working with the family and the child. In some services, this might be very formalized, that is, a diagnosis is going to be conducted before intervention. For others, it's less involved than a diagnosis, but more of the nature of gathering a profile of the child's difficulties, how they're progressing in relation to all their developmental milestones, and how they're engaging and performing in all their skills, to develop some goals to work on and identify which therapists are the most appropriate. Then there is some mechanism by which this is fed back to parents, where these goals are agreed upon. Most services are moving towards using what's called an Individual Family Support Plan, IFSP, which is really a document that states out a series of goals that everybody agrees is going to be worked on and identifies the methodology by which this will be achieved. This is then reviewed at some periodic interval, for example, every 6 months, every 12 months, to see how the child is progressing. So initial assessment, or otherwise known as a developmental assessment, can consist of a wide variety of activities. And it really is established practice that varies across services of which of these activities are done and in what order. but they will include interviewing parents to gather information about the child's development, how they're doing at home. It can involve asking parents to complete questionnaires or asking preschools to complete questionnaires. It can involve therapists conducting play-based assessments either in the clinic or at home to get a basic sense of how a child is engaging and what skills they are showing and where the difficulties may lay. On occasions, it can involve observing the child in free play, both at home and in a preschool. Many centres will focus on conducting what are standardized assessments. That is where you have a standard protocol of where you present to the child a task, an activity, or a request to see how they respond and then score them on that. And there are a number of items of which this is done, of which there is a standardized way of scoring it that then allows you to compare their performance to other children of the same age. And really with standardized assessment, you are looking to gather scores to identify where on the norm distribution curve this child will fit. That is, in the idea of the theoretical 100 children, with the first percent being the lowest level of ability and 100% being the highest level of ability, you're looking to see where the child is going to lie on that continuum, on that percentile, so that you can make estimations of whether the child does in fact have a disability or not. There are other more standardized or curricular-based assessment activities that can be done, but don't tend to have standardized scores. That is a percentile score that places a child on a norm distribution curve. There's still direct assessment. You're doing something with a child to see how they respond and then scoring them up, but they're much more on a curricula of abilities under different domains. So for example, their speech, their understanding of language, their cognitive ability, their fine hand motor coordination, their overall body coordination. And in each of these areas, you try activities and identify the specific skills that they're able to show and the ones that they are not able to do, that allows you to get a basic sense of where they are developmentally. Some services emphasize also conducting a home observation, which really means going to the family home and observing the child doing normal activities as part of the typical routines to get just a broader perspective or a broader understanding of what the child does outside of a clinic. And this can also include going to preschools, again, to see how they might be performing naturally, watching them and observing them without interacting, and also giving you a chance to interview preschool staff. So for many services, a developmental assessment begins with conducting some interview, most commonly with parents first. Most services look at gathering information from parents as the primary task or the first task that's completed to get as broader understanding as possible of the child's development. Now, some of this information may have already been contained in previous reports that came with the referral, but typically clinicians will conduct an interview to gather more information or verify it. Now, the nature and the content of these interviews vary across services. There's no one established way of doing it, and can consist of either structured interviews or more formally developed ones, which are a product of the specific clinicians themselves creating their own interview questions. Whichever of the methods that are utilized, whichever forms people use, they tend to contain the following types of questions and information. First, people make an effort to find out as much family information as possible. So who's in the household, who are the siblings, their age, what they do, attempting to find out what kind of activities that the family do as part of the typical week. Sometimes part of this interviewing or part of the information being gathered is also to establish whether in the immediate or extended family there are other people who have a disability or have autism or some other chromosomal disorder. This is usually diagnostic in purpose. That is, conditions like autism tend to have a high level of heritability. And by having a high level of heritability, that means that it's more likely to be found in the extended family and can be used as further evidence or support for the idea that when the assessment is being conducted on this child, that autism is in fact present. So another topic or area that might be covered in an interview with a parent at those initial stages of them entering into the service, and part of that initial assessment or developmental assessment, will be exploring further the reasons for concern or the reasons for the referral. So clarifying what the therapist who had made the referral had said and what they thought might be going on. I think it's also important at this stage that we pause and spend some time with parents to identify their understanding or establish their understanding of why they have been referred to the service. Why do they think they are here, and what do they think the purpose of this assessment is? Don't be surprised at the degree to which parents don't fully understand why they are now currently in this service and the purpose of the assessment. Also, to establish with parents, what are they looking for? Frequently, we can make assumptions as to what they're attempting to gain by having this assessment completed. And by simply opening it up for discussion, we may find that what they're really looking for may not be the same as what has been expressed by the person who originally made the referral. For example, the speech and language therapist in primary care speech and language therapy, or the public health nurse, or the pediatric consultant. Even when a parent is quite clear that they're looking for a diagnosis, unpacking that, probing further to establish what would that mean for them if they did get the diagnosis, what would they see happening, and what benefits would come from it. We can actually get a more detailed appreciation of the real reason they're looking for that diagnosis, which may be they're looking to access some resource, they want to get into a unit, a preschool unit for their child with autism, or what they're really looking for is just help. They want to know what to do, and they feel that if they get that diagnosis, they'll then be able to access the services that will guide them. Another thing that we typically cover when doing that initial interview with parents is getting information about the birth and also the pregnancy. Typically, what's being looked for is how well did the pregnancy proceed? Were there any difficulties? Was there stress? Were there any illnesses with the mum, or any irregularities that required involvement from the gynecologist? It is useful to find out in which week did the birth occur. For example, is there prematurity? And what was the birth like? Did it occur by natural delivery? Was it induced? And was it an emergency birth? And this is a technical term, that if there was an emergency induction or C-section, this means that there was someone that was concerned about how either the baby or the mother was doing, that required things to be done at an earlier point than was being expected. Emergency doesn't refer that things happened in a panic. Also, were there any difficulties during the birth, which is referred to as traumatic birth? Other details that can be useful to find out is what was the APGAR score. The APGAR score is a 4-item 3-point rating that is done when a baby is first born, that checks for the circulation, their breathing, and their responsivity. Very high scores are good. The lower the score, the more worrying it is for their overall development. And we also want to find out things like, did the child attend the intensive care immediately after birth or soon after birth, or what can also be referred to as the NICU, the neonatal intensive care unit. The reason that we pay attention to a lot of this information is it may explain why this child has a global developmental delay. It may be that there was extreme trauma at birth where the child stopped breathing. Another reason that we do it is it guides us diagnostically for children with autism, because there does seem to be a higher likelihood of autism for children who are born premature, if there were difficulties during the birth, and if children attended the intensive care. One of the things I'd alert to you at this point is we need to be quite thoughtful about not only how we ask this information, but what we end up doing with it. We'll talk later about, when we write reports, the relevancy of what we write. But quite often people ask this information because it's established practice to do so, without necessarily having clarity as to what they're going to do with it. We need to remember that these are not neutral questions for parents. These is not just facts that they're giving you. They will be reliving experiences that have the potential of having been very difficult and very worrying for them. Most parents who have experienced difficulties during their pregnancy or during the birth, or have had their children in intensive care, will find it quite difficult to describe without being catapulted back into those events with all the emotions that went with it. But as a rule of thumb, it is probably more useful that we get this information, that we have it there, and then make decisions of what we do with it later on, than to not gather it and then have to go back and ask it. I think what I'm alerting everyone to is the idea that this needs to be done thoughtfully and sensitively, and that we may need to, as we do this mindfully, be aware that we have to enter into that experience with the parents and spend some time with them on it, if that's what they require. Similarly, another area that we explore as part of this interviewing process is the child's infancy. That's the first year of life. What we're particularly interested in knowing is how well the child slept. Were there any significant illnesses? Did they spend a lot of time being ill? Did they have to spend time in hospital where they may have been removed from normal everyday enriching experiences? What was their responsivity like? In other words, did they show alertness to their environment? Did they show alertness to people? Did they smile? Did they seem to engage in exploring materials? Did they show interest in back and forth reciprocal games with adults? We can also ask questions around bottle feeding versus breastfeeding. Were there any difficulties, and how did the child transition to solids? And we can also ask questions around hearing. Again, like the birth and pregnancy, it is established practice that we ask these questions, which is typically, again, diagnostic in function. That is, we do understand that there is much more likely to have been difficulties in all those areas for children who are later diagnosed with autism. There's no neat algorithm for this. There's no established correlation that we can rely on as part of some standardized assessment, but it can be used as part of clinical judgment and synthesis of information to alert us to a profile of atypicality or difficulty in overall development. But again, we can be talking about a period in a parent's life that was highly emotional, very difficult, that could have involved a lot of sleep deprivation, a lot of marital conflict, a lot of isolation from the broader social world, and can be drawing up a lot of emotions and memories for parents. So again, the way that we proceed with this needs to be thoughtful. One of the most standard aspects of interviewing parents is to gather information about the establishment of early developmental milestones, particularly with walking and with language. Again, these are highly associated with delays in development. Very interestingly, they're highly correlated with general learning disability, or what can be called global developmental delay, GDD. More recent research suggests that it's not so highly correlated with autism. So if you have established that there were delays in coordination and language, this can be highly indicative of a child having a global learning disability, but not so indicative of them having autism. So we look for at what age did the child sit up unaided, when did they start crawling, when did they start cruising, and when did they start walking. We look for when the first words emerged, when did they start using two-word phrases, when did the child start pointing. As an aside on the way that we gather information and write reports, there does seem to be quite a variance in the way these are written up or recorded. In some reports, you'll see people refer to simply that the child met early developmental milestones with coordination and language within the expected time frame or the expected period. In other reports, you'll see the specific months of which these were achieved described. For me, I think it's important that we do include in our gathering information the months in which these were achieved. In that way, we're not outlining our conclusion without making it quite clear on the data which we've done it. By that, I mean that when I read a report from another clinician and they simply assert that the child met their developmental milestones within the expected period, I am unable to make the conclusion if that's accurate or not, because I don't have the data to make the same determination on myself. And unfortunately, there does seem to be some variance in what is considered to be the expected times in which people are meant to achieve certain milestones. For example, I've seen reports where it has been asserted that a child was walking within the normal time period, and when you sit with a parent and discuss this, find that they in fact weren't walking until they were 16 or 18 months of age. And that would certainly alert to you that there may have been something that you'd want to explore in greater detail as to why that was. For most children are certainly walking between 10 to 14 months. So whereas 16 months may not represent a specified delay by a criteria, it certainly is something you'd want to think about as to why it was so long before the child was walking. In many diagnostic interviews, such as the diagnostic interview for social communication disorders, the DISCO, or the ADIR, the autism diagnostic interview, they make specific reference to checking with parents when they first noted concerns. There's two aspects to this. That is, at what point did a parent first start to become concerned? For example, when the child was 6 months of age, or 12 months, or 18 months. And then, in retrospect, when they look back now, when they look at their child's development, often in comparison to other children's, when they've had a chance to find out a little bit more about typical development, what else did they notice? There are a couple of reasons for this. For many, many parents, they actually became concerned very early on. They may have lacked the language or the technical knowledge to explain exactly what it was that they were noticing, but they certainly felt something. And as the child was progressing and more difficulties were arising, or they started to see other children and noticing their children wasn't doing the same, it became clearer and clearer and more articulate in their mind. So one of the things is to assist a parent to go back over when their first concerns arose, and then to help them find language as to the other things they may have noticed over time as the child is progressing. Again, something we want to do very thoughtfully and very sensitively, because again, many parents are going to feel significant guilt that they have let their child down for not having noticed things soon enough or not having done enough about it earlier on. Alternatively, there will be other parents who in fact had no concerns, and in fact the reason they are getting this developmental assessment was because another professional, speech and language therapist, a public health nurse, has actually identified something that they were themselves not aware of and have referred them to the early intervention service for an assessment. What we need to be mindful of here is that, again, there can be significant amounts of guilt for not having noticed things earlier, or there can be very significant anger or distress that they don't feel an assessment needs to be conducted. So one of the things we want to be doing from very early on in good developmental assessments is establishing where a parent is at with this assessment, what their understanding of the assessment is about, but also why it is being conducted, what has led them to here. Some services will put energy and time into gathering information about the previous assessment and intervention history. So whereas there may have been a referral from a particular source, again, primary care, speech and language therapy, the public health nurse, the GP, there may well have been a variety of assessments that have been conducted by the time the child is actually getting their developmental assessment. It is well worth the effort to spend time on this for two main purposes. Purpose one is to gather what information has already been established by previous clinicians, to put it into context of who noticed what and when. We do not need to ask questions to a parent when they've already been asked by other therapists previously and they've already gathered that information. We already have the information as to what the child was like in infancy. We don't need to repeat those questions. Second purpose is in our attempt to understand the parent's journey, where they are at with this assessment and what their experience has been like. Understanding the journey that they have taken through a variety of assessments with a variety of clinicians, how those referrals were made, what the parents thought of those referrals when they were made, how long they had to wait for the next therapist or the next service they went to, the kind of answers they got and what they thought about those answers are incredibly helpful to inform us on how we're going to work with this family. They're incredibly helpful to understand the emotions that are going along with this assessment, right from confusion and distress that this is happening at all and not knowing why, right through to the other end of extreme anger because they've had to fight and fight and fight to get their child assessed and have been delayed and waiting and delayed and waiting until they finally got to the place they truly believed they needed to be at. Knowing where a parent is along on this continuum should guide and inform how we're going to interact and the kind of activities we're going to do. And finally, another common area that is explored through the interview is how the child is functioning daily or with the activities of daily living. We often refer to this as adaptive behavior. That is, what is their daily use of language communication now? How are they dealing with the everyday activities of dressing, eating, feeding, toileting, playing? How are they dealing with going out into the community, getting in and out of the car? What's their social behavior like, and how are they showing appropriate social behaviors? And what's their coordination like, both with gross motor, that is the large body movements like running and kicking and jumping, as well as fine motor coordination, which is really finger or hand manipulation, such as putting blocks together, drawing, using scissors, coloring. So again, there are two formats with which this can occur. One format is that this is an informal interview conducted by a therapist who's very familiar with the questions and simply is having a conversation, may have a checklist available or may simply be a mental checklist that they're proceeding through. But either way, they're doing it in a more informal way. It ends up being a conversation of which various questions are asked at various times and notes taken. Second format is where it is much more structured. There's question 1, there's question 2. These are written in a form or a questionnaire with the very particular questions there and the answers placed within it. There are pros and cons to using both. Some servers will in fact send out a structured developmental history questionnaire ahead of time. And again, there can be a lot of benefits to allowing parents to see the questions give them time to think about them, and have them write them down and submit them back to the clinic or the clinician before first meeting up. We'll explore this at a later occasion when we start looking at the ways that we might engage with the family in the assessment process. The more informally developed questionnaires, those ones which really are ones that the individual clinician or that team have developed themselves, can be an alternative to the structured questionnaires that can be found in the developmental standardized assessment tools. Many services have them, and they do vary, and they look quite different, and the format in which they are used can vary also. It's a useful skill for any clinician to develop, and that is to type out their own one. It is a good way to learn what the questions are, to help with memory. It's a good way to create it as a mental checklist. That is, a checklist that is in your mind rather than one that you have to refer to on paper. It's also good because it allows a commonness of language between various clinicians and disciplines. It ensures that we're all looking for similar things and learning from each other what other therapists or clinicians might be looking for. Another aspect of developmental assessment, particularly in this initial stage where we're doing interviews with parents, which typically occurs before we're spending time with the child or doing any formal standardized assessment, is to have parents complete adaptive behavior questionnaires. There are several of them. The two most common are the Adaptive Behavior Assessment System, the 3rd edition we're on currently, and the Vineland Adaptive Behavior Scale, which is also on the 3rd edition. There are others. There are ones that other disciplines may use. There are things known as the PEDI, which many occupational therapists will use. But for the purposes of this section, we're going to focus on these two. And again, questionnaires are something that can be administered in a variety of ways. There are things that can be sent out to parents to complete and send back, or they can be used as an interview, as a structured interview, or as the basis of which an interview is being built around, of which the answers are placed in by the therapist. So if you're using it as a questionnaire, you take the parents through each item one by one and get them to do the rating for you. In the second format, you're having a conversation, asking general questions and answering the questions to yourself and doing the ratings yourself, and then probing further where you need something more specific to answer questions that aren't coming up as part of that conversation. Again, there are pros and cons to the various methods that are used here, which we'll explore at another point. Whereas in most services, doing a parent interview and getting the questionnaires completed is one of the first activities done as part of a developmental assessment, then what follows is the standardized developmental assessment. That is where a child is brought into the clinic and they are administered a standardized test with prescribed activities that are administered in a precise way, and each item is scored, and these scores are added up to provide an overall score where it allows you to place this child on a norm referenced distribution curve, again where they fall from the theoretical 100 children, where they fall in the percentile from 1% being the lowest to 100% being the highest level of performance. The most common of these, the one that is probably found in almost every service, is the Bailey Infant Development Scale, which, depending on the service you go into, is either on the 3rd or 4th edition. The 4th edition has come out recently, but most services are still using the 3rd edition. The Bailey Infant Developmental Scale, the most recognised of tests in Ireland, is divided into 5 domains, 3 of which are administered to the child directly, and the other 2 are gathered from questioning the parents. The 3 areas which are explored directly with the child in a clinic where they're given activities are cognitive ability, or the cognitive domain, their language ability, and motor ability. The next most common standardized developmental assessment test is the Griffith Mental Developmental Scales, or the Griffith Scales of Child Development, which is on its 3rd edition. Much more common in countries like the UK, Australia and South Africa. This has grown in popularity in the last 10-15 years, and there are a number of services that are doing it, and training courses can be delivered in Ireland. Similar in many ways to the Bailey, it is one that has a larger age range. The Bailey goes from 1 week to 3.5 years. The Griffith Scale of Child Development goes from 1 month right through to 6 years of age. So as a part of developmental assessments, another task that might be conducted, and is often conducted in many services, is that of cognitive testing. Now, just reminding ourselves of the difference between what is a cognitive test and a developmental test is that cognitive testing focuses predominantly and mainly on assessing a child's overall cognitive functioning, or what we think of as intelligence. It is exploring much more that abstract idea of intellectual ability, whereas developmental tests are focusing much more on how well a child is progressing in their overall development, or the development in various areas of development, such as cognition, language, coordination, and interaction, and social behavior. In cognitive testing, we are administering a range of tasks that are exploring cognitive domains of ability, such as the overall IQ score, or overall intelligence quotient, verbal comprehension, fluid reasoning, working memory, and processing speed. Developmental tests focus on a variety, extend their assessment to a variety of areas beyond just cognitive ability. As well, developmental tests tend to build up their scoring process from identifying the typical types of tasks children can achieve at various ages. And in this way, it has much more of a criterion reference scoring system. That is, at 6 months or 12 months or 18 months of age, 80 to 90% of children can do this task, such as stack a number of blocks, complete an insert puzzle, find an object when it is placed under a cloth. And so they develop their domain scores, the scores within cognitive ability, within language, within coordination, based on how well children do with these developmental milestones of abilities. Now, at the end of the day, with a developmental test, it is still an overall score that is placed on the norm distributed curve. That is, what percentile does this child fall in comparison to that theoretical 100 children? Again, 1 percentile being the lowest level of performance, the child that comes last, 100% being the best performance, which is the child who comes first, and the overwhelming majority of children who come somewhere in the middle, somewhere between the 35th and the 65th percentile. There is some age factor that comes into the decision made of whether it will be a developmental test or a cognitive test in many occasions. So for very young children, for infants, for toddlers, most frequently, almost always, there's going to be a developmental test. With children who are 3, there can be a mixture of both, or dependent on which service that you're in. Cognitive tests are frequently quicker to administer. Developmental tests are ones that take longer and often will involve more than one therapist. And by the age of 4 or 5, it is predominantly going to be cognitive tests that are administered to make decisions of whether a child has a global developmental delay. More often than not, when it is a diagnosis for autism, it's going to be a cognitive test that's administered rather than a developmental one, unless the child is very young, for example, still an infant or just becoming a toddler. A standardized developmental test that is very popular overseas, particularly in America, but not utilized so predominantly or so widely here in Ireland, is the Mullen Scales of Early Learning. It's probably the most popular one in the United States, and you can find it in other places. Simply putting it there as a reference for you to be aware of. It's got some elegance to it and is used in a lot of research, but for some reason doesn't seem to have really taken off here in Ireland. In some services, and particularly for children who are much younger or are resistant to completing standardized assessments, an initial assessment or a developmental assessment might involve the interview, might involve questionnaires, and then some more play-based assessment, which will always involve direct assessment where you're doing something, you're playing with a child with a variety of toys to see how they play, they engage and participate, but also to some free observation. In other words, allowing the child to play the way they want to or play with their parent just to see what happens. And some services place great emphasis on making a home visit either a component of an assessment and even an essential component, or in fact where they focus their assessment. In other words, the majority of it occurs in the home rather than in the clinic. It depends very much on which service that you work or do a placement within, what you will find. Some services see it as simply an optional extra. Some services make it just an essential component on top of doing standardized and clinic work. And in some services, wherever possible, they'll do the assessment in the home rather than bring the child into the clinic. The logic being that you're going to see much more of not only how the child behaves in their natural environment, but you're going to see a greater variety of behaviors. You're going to get a better sense of what they're able to do with a variety of things. And both the child and the parents are going to be more comfortable. Another way of looking at this is we must always be conscious that conducting standardized assessments or assessments in clinics involves bringing a child into a strange place to do strange activities, or activities which at least are unfamiliar, with a strange person or a person who is still very unfamiliar to the child. And therefore we might not be getting a true representation of their abilities. Another task that might be completed in many services, particularly for children of that age, is a visit to the preschool. Again, to either conduct a naturalistic observation, just watch the child doing their thing in the preschool, and also to get some basic information from the preschool staff. Many services will also have a questionnaire that they'll send out to the preschool to have completed before they're doing the visit. And if a visit's not possible, to rely on that questionnaire and maybe just follow it up with an interview. And the final method that can be used in some services, though not as commonly as used to be many years ago, is to use a curriculum approach. And a curriculum approach is fundamentally doing a range of activities with a child to see how they are able to complete tasks in a checklist, and a checklist in a variety of areas, in a variety of domains of development. There are a number of them. There are some that are more focused on learning disability, like the Carolina curriculum or the Portage. The Portage is one of the earlier ones, followed by the Carolina curriculum. And there are some that are based much more within autism, such as the Early Start Denver model, or the longer established assessment of basic language and learning skills, or the ABLES. Again, there are some great pros and cons to using curricula. They do provide you an enormous amount of detail as to what a child can do. The curricula tends to be checklists that are developmental in order. That is, they start off with skills that are seen with much younger children and then progress through that checklist to skills that are seen in much older ages. So they allow you to not only get a baseline of where a child is at in any one domain, for example, understanding language, talking, fine motor coordination, play. They also allow you then to set goals very neatly, because where you reach to their basal level of ability, that is what they can do, and where they're starting to show they don't yet have skills, gives you immediate reference to where you're going to focus your intervention with what your goals are going to be. But they also allow you to monitor very effectively over time how well a child is progressing. Typically though, curricular assessments do not provide standardized scores. They're simply a checklist of skills that are developmental in order, that is, from the lowest level of ability to the highest.